He is the chair of the Foot and Ankle Department in Colorado University, USA. And we will start while hearing his talk on Achilles tendinopathy and new concepts.
Yeah, thank you, Peter. Can everyone hear me okay? Okay, so it's an honor and a privilege to be here. Where the I think he's bringing it up. All right, it'll make life a little easier for me. So it's a privilege for me to be here. So I want to thank Aspetar, ISACOS, and FIFA for putting this outstanding conference together and for letting me be a part of it. So I'm going to speak about Achilles tendinopathy, which is an issue that anyone who takes care of athletes, particularly football and soccer players, is going to see in their practice. So I have no financial relationships to disclose. I'm a member of a number of committees, but nothing financial. So as Peter mentioned, I came from Denver, Colorado, which is on the eastern side of the Rocky Mountains in the U.S. It's a beautiful town. I actually just moved there about 4 months ago from Stanford University. So it's called the Mile High City because it's actually at 1 mile. Very outdoors oriented. So the population is very active. This is where the University of Colorado where I practice. Population is quite active. We also have 5 professional sports teams, including a pro soccer team and an NFL team, which just 4 days ago won the 50th Super Bowl. So we're the reigning Super Bowl champs. So the burden of Achilles tendinopathy is that it's a very common problem, particularly in running, jumping, and cutting sports. Dr. Mafuli showed us that the lifetime prevalence in runners is about 50%, so it's very, very common. Also common in soccer, and it's problematic as well. It only accounts for about 4% of time off in soccer, more common in older players, but about a quarter of these injuries are recurrent. So not only is it a common problem, but it's commonly coming back, and as this is again Dr. Mafuli's group pointed out, a short recovery period was a risk factor. So if you don't give them the time to rest, they're more likely to have this rear up. And obviously what we want to avoid is rupture, which can happen with a degenerative tendon. So if we look at the anatomy and histopathology of the tendon, the Achilles is the largest tendon in the body. It's the strongest tendon in the body. It's where the gastrocnemius and the soleus come together, about 15 centimeters above the insertion. So those are very strong muscles, and the gastroc actually crosses the knee and inserts on the back of the femur. So a lot of force is seen on this tendon with any activity, but particularly when you're running, jumping, and cutting. So there's a watershed area similar to bones that were discussed in the last session. There's an area of poor vascularity, and this is the risk zone. This is where a lot of the injuries are going to occur, both with degenerative tendinopathy and with rupture. There are 2 bursts at the insertion, which can become a generative pain, as I'll talk about in a moment. So the etiology of tendinopathy is still not well understood. We know that it's probably a combination of decreased vascularity with multiple repeated mechanical injury. So as these little micro tears develop, if the body can't heal it because it's still seeing mechanical injury and there's not good vascular supply, eventually it can start to degenerate and then ultimately fail. So there are a lot of predisposing factors, and you'll find that there's some overlap with bone stress injuries, and certainly there's overlap with ruptures, which we'll talk about in a few minutes. But this is wear and tear. This is activity related. This is a lot of mechanical stress in somebody who's not mechanically equipped to accommodate that stress. So high arches, bad footwear, going from no workout to high workouts, poor flexibility, et cetera. All of these are going to put athletes more at risk, and a lot of that describes soccer players. Medications can also increase the risk. Fluoroquinolones have been shown to create a 3 times higher risk of tendinopathy, and it's 9 times higher if you add a glucocorticoid medications. Statins are also something that's receiving more attention, probably not as prevalent, but there has been a link in the literature. So when we look at this histologically, and it's important to understand this when we talk about the treatments, this is not an inflammatory process. It's really a degenerative process. So inflammatory cells aren't typically present. What we see is abnormal collagen, increased neovascularization. We don't see prostaglandins and other inflammatory factors. So that becomes important as we approach treatment. So I'll divide this up into non-insertional and insertional because they're really two different entities. Even though it's the same tendon, it's a very different approach to treatment. Non-insertional is in that watershed zone typically, kind of above the insertion, whereas insertional is down near the calcaneus. So when we evaluate these athletes, it's very important to pick out where the problem is clinically. So we'll inspect them first to see if there's prominent bone, thickening of the tendon, obviously make sure their skin's intact, and then you want to palpate. Where's the site of tenderness? Other lesions like an osteotrigotum can also mask, so it's important to look elsewhere to see if it's just the Achilles. You want to localize it to where the site or sites of pain are. Check their range of motion. Silverskold's test is the separation of the Achilles from the gastroc. When you straighten the knee, the gastroc's tight, and so you can determine whether it's an Achilles tightness or a gastroc tightness. Then you want to look at strength. The single limb heel rise is a very good test to see if they're limited in their strength because of the Achilles. I'll get x-rays on all of these to see if there's calcification. You can also see the thickening of the soft tissue shadow in Achilles tendinopathy. And of course, with insertional problems, you want to look at a Haglund's deformity or prominent calcifications. Ultrasound and MRI are very good to both localize and identify tendinosis. So if there's a real problem that needs to be addressed, it's very important to know where it is if we're going to consider an intervention for treatment. So I always approach it in 3 phases: non-operative, which is the start for all Achilles tendinopathies, and then I'm going to talk about some non-classic procedures that are gaining popularity. I'll just mention those that have some evidence, and then obviously surgical procedures. So non-insertional tendinopathy, this is the more common problem. It's also more common for it to respond to conservative care. So rest becomes very important. It's very important to take away the repeated mechanical strain for a period of time, allow the tendon to regenerate a little bit, and before you start stressing it again. And then you want to correct the mechanical problem if it's present. So corrective insoles, making sure their shoes are appropriate. Eccentric strengthening is sort of the mainstay of conservative management. And all the studies, or the majority of the studies that show other treatments to be effective, it's always better when it's combined with eccentric strengthening. And then obviously stretching, and then ultrasound and iontophoresis and other therapies that trainers and physical therapists have can also be very helpful to reduce symptoms. So Alfredson's eccentric strengthening protocol is still sort of the mainstay, and it becomes an important adjunct as we talk about some of these other procedures. So there are 3 non-classic procedures that I'll mention. The first is PRP, platelet-rich plasma. So the concept here, or I'll mention first, there was a sort of a media frenzy after 2009 when one of the Pittsburgh Steelers famously got PRP before the Super Bowl and was able to get over his hamstring issue. So it became very popular. A lot of very well-known athletes in the US were receiving this treatment. It's tapered off a little bit in recent years, but for a long time it was all over the media. It's now being used in professional soccer in the US. It's not widespread as it is in the NFL, but it's definitely a visible procedure for athletes. So there's not a lot of literature on this, believe it or not. There are only 5 studies. One of them was published for a second time. Most of them are small series. There's one randomized control trial. What they show is that it works. It does reduce symptoms. It improves function. It allows these athletes to get back to play. But the randomized control trial showed that it's no different than a saline injection. So it does work. The question is whether it's better than other treatments that might be possible, and that remains to be seen. So what's in PRP? It's basically growth factors that are concentrated. So the concept is the patient or athlete's blood is drawn, they spin out the red cells, the white cells, and they concentrate growth factors, and then it gets injected into the area of the tendon where there's not a lot of vascularity. So that's the concept, but there are a lot of different formulations, and there's a lot of different approaches to each of those formulations, and each company does it a little bit differently. And then there's several factors that impact the effectiveness of the treatments as listed there. So there are a lot of things that can make one PRP different than another. So there's clear differences between individual companies. One of my colleagues at Stanford, Jason Dragoo, looked at several of the companies that make PRPs, and they would spin it down from the same patients and get very, very different results, like multiple times different results for each formulation. So there's no consistency in what you're actually injecting. And all published studies use different PRP protocols and different companies to spin it down. So we really need some more similarity between what we use for our research and for our procedures to make statements. So does it work? Yeah, it probably does, but we don't know what the right formulation is yet. So more research will probably show, but the area is certainly not dead. And we do need some standardization for clinical trials. So one of my colleagues, Alan Mishra, put together kind of a nice and relatively simple classification system for PRP, which separates them out by white cell content, activation, and platelet concentration. Something like this can guide research so that at least we're all speaking the same language when we're looking at studies on PRP for all of its indications. So PRP is really it's a young field. I used to say a field in its infancy. Now I say adolescence. It's moving along a little bit. More well-controlled studies are needed, and that's the problem as often exists with an exciting new technology. A lot of people are using it, not a lot of people are publishing on it, so we need a little bit more of that to understand whether and when it's really effective. So shockwave therapy is a treatment that Peter mentioned for bone stress injuries. It can also be effective for tendinopathies and fasciopathies. So there's sort of two versions. Low energy is the easier one. You can do it in clinic. The idea is that there's a short-term analgesic effect because you're drumming up the cells and reducing the discomfort. Long-term, the idea is you're increasing inflammation so that the tendon can begin to recover and regenerate by increasing the neovascularization and essentially stirring up healing through trauma. The advantages are you can do this in your clinic. It's not terribly expensive. Doesn't hurt the patients, and there's really no risk to it. So this is something that's pretty easy to add. There's also some decent evidence. There's 6 articles, 4 of them are RCTs, that show significant improvement with shockwave compared to other treatments. And again, it's best when used in combination with eccentric loading. But it's better than eccentric loading alone. So the high energy devices are a little bit less prevalent, at least in the United States. So the mechanism is the same. The downside is it's a bigger machine, it's more expensive, and it's more painful. So you have to go to the operating room and put the patient under anesthesia for about 6 minutes. That makes it more expensive. Insurance companies won't pay for it, so it becomes quite an out-of-pocket expense, particularly in the US system. So there's 2 clinical articles. They're by the same author, but it did show that this is an effective device for Achilles tendinopathy. So the final is the RFA and ultrasound wands. So these are becoming popular now in the US. The idea is that you mechanically disrupt the tendinosis, and you also use the ultrasound or the radiofrequency technology to stimulate healing, to upregulate the fibrocytes and stimulate some healing. The real downside is that there's a serious lack of evidence supporting either of these treatments. RFA has to be done open, it has to be done in the OR. The 10x unit you can do in clinic. So these are becoming more and more prevalent in the US, but again, there's no data for the Achilles. There's one paper on RFA, but there's really not a widespread evidence that this is effective, so it's not something that I use routinely in practice. So these are good, safe alternatives to surgery in select cases. You have to think about what's going to be best for patients, particularly if you're taking care of elite and professional level athletes. You have to be mindful of the competing forces to getting them back to play safely and efficiently. But we really need more high quality data. So cortisone I avoid in athletes entirely around the Achilles tendon. You just don't want to weaken a tendon that's already degenerative and risk rupture. As we'll see a little bit later, that's a much bigger problem than tendinopathy. So surgical treatments, the concept with surgery for Achilles tendinopathy above the insertion is to get rid of the bad tissue. So you want to resect the degenerative tissue through some means, release any adhesions, as was alluded to in Peter's first talk, and you want to stimulate healing with controlled trauma. So the classic is an open tenosynovectomy and debridement of the tendon. So you find the bad tendon, you take it out, you repair what's left. Percutaneous tendinotomies have been described. The endoscopic technique is sort of up and coming. So you can get to the tendon relatively easily endoscopically and resect the tissue, but again, the data is not yet there to support it. So a very nice study that just came out last year by Kahn's group was a meta-analysis of 60 studies over the past 50 years, and they showed, on average, the success rate for open debridement of an Achilles tendon was 84%, which is pretty good. What I thought was most interesting is that when they looked at the methodologic quality of the study, and they found as the quality got better, the outcomes got worse. So obviously the better studies that are really looking at the right data are probably telling the real story over those that are of lower quality. So endoscopic debridement has been described. This is courtesy of my colleague, Kenneth Physical at the University of Iowa. So it's actually quite easy to get to the tendon and debride the bad tissue. The advantage of this is it's less invasive. You're not disrupting the blood supply. So there's some upside. The downside, again, is we don't have evidence to support it yet. So finally, insertional tendinopathy, again, this is a bit of a different entity. Part of it is the tendon degeneration, but it's also inflammation of the bursa and typically a bony pathology that's associated, a Haglund's deformity or calcification within the tendon itself. So non-operative treatment is still where we start. In my experience, patients are less likely to respond to non-operative treatment with this than they are with non-insertional. We'll change their shoes, give them a heel lift, take out the heel counter so they're not getting chronic irritation. Again, shockwave can be useful. Not a lot of data on the non-surgical treatments like there is on the insertional treatments like there is on non-insertional, but it's still where you want to start. So the idea with surgery is you want to address three things. One, you want to debride the tendon. The way you approach it, in my view, is you go where the pathology is. If it's central, you go central. If it's medial lateral, that's where you go. You always want to remove the bony deformity. So that can be done through any of those open approaches. You want to reattach the tendon if you need to. It's not always necessary, but it can be helpful, particularly if you're taking a lot of bone. Transferring the FHL, I'll talk about in a moment. That's primarily for patients with severely degenerative tissue, and it's probably not ideal for a young athletic person. Endoscopy has really come around. This has become my preferred treatment for patients that don't have a ton of tendinopathy. The concept is, again, as Peter spoke about in his first talk, you can get to the Haglund's and to the tendon endoscopically. So this is a 26-year-old running athlete I took care of just recently. Had 9 months of pain, had gone through all the conservative treatments, was not getting better. And his MRI showed, excuse me, this Haglund's deformity, which was clearly irritating the tendon. But all of the degeneration was on the anterior side of the tendon. It wasn't really in the substance. So as long as there's not extensive degenerative changes through the tendon where you're going to worry about weakening it with a scope, you can do these endoscopically. So Dindo, if you don't mind clicking on that video for me. So with the scope, you always want to start by debriding the fibrous tissue at the, if you don't mind clicking on that. Thanks. You want to debride the fibrous tissue first with a shaver. And I use all small joint instruments, so this is a 2-9 shaver. The tendon is to the left, and obviously the pathology is to the right. So you want to remove the inflamed bursa and all the fibrous tissue that's covering up the Haglund's deformity. And then I use a 2-9 or a 3-5 burr to remove the spur. It takes a little bit of time because with a big, you're not resecting a lot of tissue at once, but you take the time you need to make it nice and smooth, then you get down toward the insertion. Once you identify the insertion, and I use a small needle to sort of confirm that I'm at the insertion point, then you debride the tendon. So you take away all the degenerative tissue, you use your MRI as a guide, and then you have a nice clear interface between the bone and the tendon, and that's kind of what you're looking for. So the concept is you're able to do everything you need to do without making a big incision, disrupting the blood supply, and creating the scar that often happens with that procedure. So there's a very good retrospective study on 28 patients at 3 years, and they were all doing very well. So there's not a lot on athletes, obviously, because it's a relatively new technology, and we tend to do those in athletes later in the game. But I think this is will be a very good alternative to the open approach in select patients. FHL transfer, this is really for patients with extensive degeneration and probably older and overweight patients. So I did a randomized control study of 37 patients. We randomized them to FHL transfer versus no FHL transfer. Found that both groups improved at 1 year, and there was not a statistically significant difference in their pain scores. There was a difference in their strength. So at 6 months and 1 year, the FHL transfer group had much better plantar flexion strength than the non-FHL group. So there is a role for it in select patients, but again, would not do this routinely in a young athlete or a soccer player particularly because they really need that FHL for function. So in summary, Achilles tendinopathy is very common. It's very common in soccer players. It may be a precursor to rupture, which we'll talk about later. Eccentric exercise is really the cornerstone of management. Avoid steroids. PRP probably is an effective procedure, but I think we need more data and more guidance to make sure that we're using it correctly and in the correct athletes. The surgical procedures are very effective, and we're evolving less invasive procedures, which might help us get these athletes back to play more rapidly and safely. Thank you.